Welcome back. This is Max's EM Weekly Update for the week of May 19th, 2026. A quick run through what's worth reading in emergency medicine, with a focus on what might actually change your thinking at the bedside. This week, azithromycin for preschool wheezers, big safety numbers on pediatric ketamine sedation, a couple of useful phone pieces, an obesity airway review, and one pre-hospital naloxone paper that needs a cautious read. First up, azithromycin for preschoolers with wheezing in the emergency department, published in the New England Journal of Medicine. This was a multicenter randomized controlled trial of 840 preschool children, aged 18 to 59 months, presenting with moderate to severe wheeze. They were randomized to azithromycin for 5 days versus placebo. The primary outcome was symptom severity over 5 days, and the trial was stopped early for futility. Bottom line, no difference. No difference in symptoms, no difference in emergency department length of stay, no difference in hospital length of stay, and no difference in 72-hour return visits. Even in the 62% of kids who had pathogenic bacteria identified, azithromycin still did not improve outcomes. It cleared bacteria from the nasopharynx, but that microbiologic effect did not translate into any clinical benefit. This is a strong negative trial, and honestly a useful one. It reinforces that just because bacteria are present does not mean they are driving the wheeze. For most of us, this is not really practice-changing, because we were not routinely giving azithromycin here anyway, but it does help shut the door on a lingering idea. Next, a systematic review on pediatric ketamine procedural sedation in the emergency department, in Annals of Emergency Medicine. This pooled 67,871 pediatric sedations across 20 studies, looking specifically at IV ketamine. The numbers are impressive. 0 deaths, 0 permanent neurologic deficits, and sentinel events like intubation, CPR, aspiration, or pressors occurred in about 1 in 11,500 sedations. Serious adverse events were 0.34%. They also found 3 modest predictors of increased risk: age 10 or older, URI symptoms, and coadministered opioids. But each of these added only about 1 extra serious event per 100 to 150 sedations. Benzodiazepines were not associated with increased harm. The takeaway here is pretty straightforward. IV ketamine for pediatric procedural sedation remains extraordinarily safe. Mild URI symptoms should make you thoughtful, not paralyzed. And the benzodiazepine finding is reassuring, especially for people who still worry about using them around emergence reactions.
2 foam reads worth a look. The first is an MDocs review on kratom in the emergency department. Evidence is thin, mostly case reports, pharmacology, and expert synthesis, but the clinical review is useful. The key reminder is that kratom can act like both a stimulant and an opioid, depending on dose, and naloxone may help, but the response is inconsistent. Not definitive evidence, but a good practical primer for a toxidrome you are probably going to keep seeing more of. The second is an EOD Ottawa piece on expanding your aortic point-of-care ultrasound exam beyond the belly. It walks through hepatic, parasternal long axis, and suprasternal notch views to broaden aortic assessment, especially for thoracic pathology and dissection. Nice technical refresher. The one caution, the suprasternal view is more of a rule-in maneuver than a rule-out test. Over in critical care, there is a narrative review on airway management in critically ill patients with obesity. No major new evidence here, but a solid framework. Main points: use non-invasive ventilation aggressively from pre-oxygenation into laryngoscopy if you can. Expect hemodynamic sensitivity to positive pressure. Make video laryngoscopy your default, and consider ketamine or etomidate as reasonable induction choices. Awake intubation may be appropriate in selected patients. The physiology all tracks. These patients desaturate fast, and the right ventricle may not love what we do during induction. The challenge in the emergency department, of course, is that you do not always have time for the full idealized setup. Still, good review, good reminders. Finally, a nationwide cohort study comparing intranasal versus intramuscular naloxone by EMS clinicians. The headline suggests IM may be superior, but I would be careful. This is observational data, so confounding by indication is a major issue. Route choice is based on real-world patient factors the dataset cannot fully capture. There was also no dose standardization, and some of the outcomes, especially transport refusal, are hard to interpret cleanly. What the paper does add is this: IM naloxone did not appear to cause more documented agitation or vomiting, which addresses one common concern, and both routes appear reasonable in practice, but this study does not prove IM is better. So, the short version for this week: don't use azithromycin for preschool wheeze expecting benefit. Keep using pediatric IV ketamine with confidence. Get familiar with kratom presentations. Expand your aortic point-of-care ultrasound skills thoughtfully. Review your obese airway setup. And read the naloxone paper with your methodology guard up. That's your EM update for the week. Thanks for listening.